everyone. We're going to get started. On behalf of the Center for Global Development, our co-hosts JSI and the Primary Healthcare Performance Initiative, I wanted to thank you all for joining us today for what promises to be an engaging conversation. Also wanted to acknowledge those joining us via webcast. I'm Janine Madan-Keller, Senior Policy Analyst on CGD's Global Health Policy team. As most of you know, leaders convened in Astana, Kazakhstan last week to mark what was the 40th anniversary of the Declaration of Alma-Ata and to recommit to primary health care. They also endorsed the Declaration of Astana. For today, we have two goals. We're hoping to reflect on some of the key outcomes from last week's convenings, and more importantly, to have a dialogue about what needs to happen in practice to move from aspirations to reality. We have two back-to-back panels in store for you today. Don't worry, we'll have a coffee break in between. And before we dive into the panels, we're going to have a conversation between Amanda Glassman, Chief Operating Officer and Senior Fellow here at CGD, and Lauren Weber, Public Health Policy Reporter from HuffPost, who we're really glad to have join us here today. Before we kick off, I also just wanted to invite all of you to join in the conversation on Twitter. You can use the hashtag CGDTalks. And without further ado, I'll hand it over to Lauren and Amanda.
Thanks, Janine. Well, thanks everyone for coming out to kick off the conversation. With the constant push for universal health coverage and the Sustainable Development Goals, primary health care is back in the news. As Janine discussed, we had the 40th anniversary of Alma-Ata. You know, it's considered necessary to really reach the next level of what we want in global health. But, you know, how do we make sure that actually happens so you and I are also not having this conversation again in 40 years?
Yes, 40 years. When I'm 88 years old. So one thing I want to say is I think we should give a lot of credit to the advocates and experts and international agencies that have made universal health coverage and primary health care part of the agenda in global health. I think we forget that it's been about 3 to 4 years of working to get the topic back on the table, and I think that we can definitely say that has happened. So from you know, the global conversation is changing, and I think the representation in Alma-Ata reflects that. But I think there's a big issue picture that would have to change between now and 2058, and that is to think about the goals of our health system as being mainly about improving healthcare. And that seems like a banal thing to say, isn't it obvious? It has the word health in it, health systems. But that said, the way that we allocate resources now, the way that we spend our money, the way we select products that we would subsidize through the public sector does not always match up with that aspiration of improving health. So, you know, there have been a lot of articles talking about, you know, an essential package of primary health care. The money's not the problem, conceptually at least, right? We know that even the poorest country in the world could afford a basic package. The issue is allocation. So it's about how we decide what to spend on, what processes are in place to allocate money progressively towards those that are most likely to benefit from the services and to those products and services that will maximally improve health. There's nothing new about that statement. It's the how that matters and the holding accountable for that how as well. So we're a little bit distant from that because we know from the PHCPI work that a lot of the data on performance of PHC, on spending on PHC is still quite rudimentary. And that is a little disappointing 40 years after the first statement. So in 40 years, I hope we at least know where we stand at minimum.
Small
and
steps.
Hopefully improving health as well.
You talk a little bit about resource allocation, but how do you incentivize these lower income and lower middle income countries to really allocate those resources or even just account for them to track what's happening in this field?
So, I mean, as people sitting in Washington, D.C., you know, we can talk about it all the time, but I do think that knowing something about the data and creating better incentives with our external assistance to low-income countries to track these basic measures of health system performance, that has to be the way. Obviously, it's down to countries themselves. There's the oft-cited political will, a bit vague. What does political will mean? I mean, it means we have to create some, as a collective community, I don't mean, country versus global or whatever, but there's not much political benefit at the moment from investing in primary health care. It's prevention. It has a cost. Many poor families, are not going to access that care unless it's very easy to access, unless it seems useful to them. So I think we need to create some moments of political visibility and goodies for politicians to support and allocate monies towards primary health care. And I think, monitoring performance is part of that. I think you could add some money to the mixture. It doesn't have to be money. It could be other kinds of reputational incentives. It could be measurement, et cetera. So I think that we need to focus on all kinds of levers that we have to give some political visibility to the gains that we can make through PHC.
And you talk about political will, and we're coming right off of the high-level meeting for tuberculosis and non-communicable diseases, and I would argue that those have been somewhat unsatisfactory, and that it was a big showing somewhat of political will, but I'm not sold on the actual action plan afterwards. So when we talk about political will, are we talking about more than kind of some joint meeting, but more something on the ground that the people can get their hands around? Or
absolutely. I mean, so. And I think similarly in PHC, there's the G4, that's right. Or the 4G. No, that's not a cellular network. It's a group
we are close to Verizon, but
Global Fund, Gavi, World Bank Group, and I can't remember.
I'm sorry.
The 4Gs, whatever, et cetera.
We got three.
I got three, right? Yes. So they all talk about. Coming together to deliver together. But the question is, how well are we structuring our external assistance now to be able to deliver for TB or whatever else? I mean, especially in the case of TB, we have been measuring a lot of stuff in TB.
Yes.
And yet it's, that first line treatment is, the quality is poor. We know most people are using in the private sector. We're not thinking about the whole system there. So I think, in this next phase, how is it that we're going, they're not easy answers. If there were easy answers, we would have already done them, obviously. Right. But, I do think we should explore, and I'm not saying this is a silver bullet or panacea, but just that we have tried a lot of stuff and we need to try new things. And that is to say, if we care about screening and making sure that there's good adherence and completion of TB treatment, let's start, creating some kind of pay-for-performance relationship between the global fund and a recipient country, for example, that would at least focus implementers on the goal of the programs, right? So that we know what our baselines are, and so that we are actually completing treatment, and we're thinking about the patients that are being enrolled as well. I mean, the other thing is the siloed funding issue comes out in TB as well. We're doing very well on TB HIV, but if you don't have HIV, we're not doing as well at reaching those communities. And those are those poor communities where we need to reallocate money more propositively in that direction.
Well, and you've beaten me to my next question, which is, let's talk about donor siloing. It's not like we're all not happy to accept donor dollars, but the reality is that often they're focused on one topic or one disease or one issue, which is kind of counterintuitive for primary healthcare as a system as a whole. So how do we kind of overcome that in the current donor system that we have right now? I mean, how do you get past kind of the siloing to work together on these issues?
I mean, we talk about how donor assistance is less and less important over time, but donor assistance is still really important for the very core of primary health care, especially in low-income countries. And I think if you look at the way that we're providing care, the rhetoric looks good, but the money still looks very chunky. I think if we could focus on the thing we're trying to achieve and not have that play back in the way that we're organizing the money, we might do better. And there's plenty of examples of this working in practice. I mean, although later problematic because of the Ebola outbreak in Liberia, there was a health pool fund in Liberia that was functional to provide a primary health care package through NGO contracting in the entire country. So, there are interesting examples like that of ways to think about the whole package together, to measure all of your disease-specific things, and to deliver on that. And I think, we're working this year on procurement and just a little bit on supply chain through procurement.
Just a little.
And in the next panel, you'll hear from one of our working group members, Clinton, on this issue. But the supply chains still don't look very integrated. They don't look very rational. They are performing well for the big items that we buy today, like ARVs and things like that. They're doing less well in maternal and child health care products. This kind of thing, after 20 years of support to developing country health systems, we should be getting better at that. We should at least be able to say that there's a set of things that we're always going to buy for primary health care. We can do it in a more rational way. So maybe we should start with these very practical measures to rationalize and to support countries to do a more coherent approach to those issues.
You mentioned the 2014 Liberia Ebola outbreak. Sadly, we're in the midst of a current Ebola outbreak in the DRC that is ongoing and shows no sign of stopping anytime soon. And a lot of the reason for it, I would argue, is because kind of a failure at a primary healthcare level. It was spread originally by a fair amount of healthcare workers who weren't trained in dealing with Ebola. It was new to the region in that area. Over 20 healthcare workers have died. It's currently being spread more so through traditional healing centers and other healthcare centers in its current epicenter. And sadly, this is not uncommon. I do believe that there are going to be more outbreaks like this. If you look at the WHO blueprint priority list, you've had more of them in the past year than you've seen in a long time. And so with globalization, with mobilization, with global travel, we're going to see more outbreaks that are really dependent upon primary health care to be stopped from the get-go. Is there a way to mobilize global health security dollars to kind of into the primary healthcare sector? What can we do to kind of help stop these outbreaks before they start?
Yeah, no, I think that's a really important point. And Vin Gupta, who will be on the second panel, will talk, I think, a little bit about these issues. But it makes all the sense in the world, of course, because so much of preparedness is about excellent primary health care and excellent surveillance, the ability to recognize cases.
Right.
The drivers of DRC are many. One has to be, there's other enabling investments, I guess, that make health systems work. So that's just one thing to say, things like security. But I don't see any reason why the global health security agenda is separate from a PHC agenda. It can certainly be mutually reinforcing, and it's also, surveillance or lab systems. That in particular, we still are seeing examples of siloed funding there too, like I'll transport a yellow fever sample because it's a vaccine preventable disease, but I won't do an Ebola.
Right.
This is the kind of petty, it's lame. We can do so much better than that. And it shames me to think that we spend any money, that we've created a situation like that in countries that would really benefit from our assistance. So, to the extent that all surveillance assistance that we provide serves for preparedness purposes, serves for the existing infectious diseases that we know about, that does a good job on diagnosis, and that is able to make the connection with treatment and further prevention. That we all know what to say.
Right.
That's what this event is about. Sort of, we know the nice words, but how is it that we can translate that more practically into more rational behavior in the real world?
Well, I'm happy to hear that. And not to go back to the siloing point and not to add another silo, but do we need some sort of primary health care accountability mechanism like the Global Fund or like, separate from the WHO, some sort of governing body to kind of oversee this more so than what is currently available?
Well, I think about this because I think about family planning, for example. That is another area. There was no tied fund for family planning.
Right.
There were a lot of groups that financed family planning, and the idea was to create an accountability mechanism, which was FP 2020, to try and create incentives for progress on coverage and delivery of family planning. And I think and to elevate the visibility of family planning. And I think PHCPI, in a way, is in that same way. It's about measuring, it's about tracking progress, it's about working with countries to develop plans and then to see how that goes. The issue now is to connect the measurement and a little bit the money. How does the money work? Both donor money, the different sources of money, and the results on the ground. I mean, at the Center for Global Development, and we talk about taking the money and matching it with the measurement and the progress. And it's not because the money is so needed. It's not, it wouldn't take a lot of money, but at least some of the money could be riding on better data, on moving forward on a plan or something like that. I guess I don't have another idea. I hope that there's another idea out there, but I feel like, we also talk about like community organizations and report cards and things like that could monitor, whether expenditure is happening. But many of our ideas, or having like, let's think of a Kenya where most of the money is county level money, and so the center could be holding a portion of the transfer to the county against some progress on some key measures, for example, complete vaccination for age, something that's not very ambiguous. But it's those, I do think that the money has to talk a little bit to the performance. I don't know how, it doesn't necessarily have to be tied, but what we see now is a total separation between the money and the performance. I'm buying a lot of inputs, and then what happens here I'm hopeful about, but I don't actually have that direct link. So ways to make that happen, there's lots of levers, but we need to think more about that and to test different ways to make that work in practice.
Well, and kind of to go into, just to broaden this out a little bit, the overall value of primary health care. In the paper that you and Janine had recently published, you say that it's 90% of healthcare costs for a country could be covered if they adequately did their primary health care. So kind of talk, what does that mean quantifiably? Like can you give me some more stats on what that is?
Well, that's not our stat. It's the World Bank and the World Health Organization that have said that 90% of health needs could be met at the primary health care level. And I think, if I then look at the money and I see 70% is in hospitals, well, that's the mismatch I'm talking about. Right. So if we, it's not that it's going to take 90% of the money to deliver 90% of the value, fortunately, right? Because there are other things people want from their health system. I get that. But it's that systematic resource allocation, tracking the resource allocation and spending to the results that we want to see that are going to make the difference. And that's hard work. I am worried when I look at a country like India that is developing this very ambitious and exciting, a really exciting national health insurance reform, but it is mainly focused on fee-for-service reimbursement of hospitals. And the primary health care part is funded through the Ministry of Health and Family Welfare, traditional input-based financing, maybe a capitation, maybe sort of vertical program funding, but there's no entitlement there. There's no first name and last name attached to those benefits. I worry, and I think Gro Harlem Brundtland also talked about this in a Lancet article recently, that system creates an incentive to overproduce hospital care and underproduce primary health care, the thing that would address supposedly 90%. And I think we have to ask ourselves, okay, well, what's going on there? And we see that in a lot of different countries. And it's politics, obviously, but it's also the purpose of the spending. The other thing that we see in a lot of countries, including a country like Brazil that has a good primary health care system in its public sector, is that public sector employees are enrolled in private insurance, for example. And that ends up being 60% of the spend, and that's true in South Africa as well. It's true in Chile. So, what are we talking about here? If I don't want your coverage through the public system, if I, as a public employee, won't accept, okay, maybe we need to insure everybody. I will be controversial. But let's think about it, right? Maybe I need to create, well, maybe I won't, I'm not going to launch out there with that. But let's say, when I look at primary healthcare systems, and others have said this, our time is up, but a lot of primary healthcare in the most developed, highest performing systems are actually private. Those private primary healthcare providers are private. And that might be because we need those production incentives at the primary healthcare level. We need that private sector constituent at the primary healthcare level. If we create it in the hospital sector, that's the sucking sound that you'll hear. Not to say hospitals aren't important, they're extremely important. So I think it's all about designing a system that produces the stuff that we know to be the highest value and thinking about how incentives link up across the systems to produce that high value care.
Well, thank you so much for your insight here today, and I will introduce the second panel now, but thanks for having us.
Thank you to Lauren. Thank you.
Good morning, everybody. Thanks very much, Amanda, and also Lauren, for really setting the tone and the scene for the session. My name's Craig Burgess. I work with JSI, and our panel is really primary healthcare 40 years on, what works and what needs to happen. And we're trying to balance the perspective in terms of the economics and the policy and the global level with a field reality. What is it really going to take in field terms to actually implement programs for primary health care? Before I hand over to my panel, this reality check, we need to get a reality check with the Astana Declaration. Just reminding you, the Astana Declaration that was announced last week, kind of the what? It's the right to health, it's PHC, equity, inclusion, NCDs, outbreaks, financial risks, multi-sector application, emergency, sustainability. That's just the what. And the how is political will, knowledge, capacity building, human resources, technology, domestic resources, civil society, and alignment. It's great. It's a great declaration. It's a bit like apple pie. Hands up here in the audience who likes apple pie. We all like apple pie, but how can we distribute the apple pie and the slices of the apple pie equitably and make sure those that are taking the apple pie actually find it nutritious? And that's what our panel is about. Our panel, we're very lucky indeed, has some key members on the panel. First is, and I encourage you to look at their bios. My brief introduction is not going to do them justice. Their bios are really go into a lot more depth of where they come from, what they've done. But Dr. Rose McCauley from Liberia has previously been the MOH director in Liberia Family Health for many years. She was in WHO Afro regional office for many years and was really a frontline health worker and responding to the Ebola crisis in 2014 and has really done a lot of thinking and action in terms of health systems strengthening since then. My colleague, Dr. Binyam Detta from Ethiopia, has also been involved with primary healthcare on many different aspects, scaling up extension workers, which of course is one of Ethiopia's leading programs and policies, of Clinton Tazuza, who's an expert from Imperial Logistics and has implemented many logistics and supply chain programs in many countries in Africa. And finally, and by no means least, our colleague Nabila Ali from Pakistan, who's had a huge range of experience on health system strengthening, maternal neonatal child health and governance, and has led many AID projects and has even received an award from the Prime Minister of Pakistan for her good works previously. So what I'm going to do is I'm going to ask each of the panelists 2 questions, and they only have 3 minutes to respond. So it's a short, sharp, concise way of thinking. And then at the end of that, after the 2 questions, we're going to open up for 15 minutes for questions and answers from the audience. So as our panelists are talking, have a think about what more you might want to hear from our panelists as they're talking. So first off, Rose, your first question. Here's some I prepared earlier. Okay, given you've been at the sharp end of the recent Ebola crisis in Liberia and at times also in Sierra Leone, what lessons do we need to learn from responding to outbreaks and the need for strong primary health care to prevent and respond to these in future? And what's worked well? Thanks, Rose.
Thank you. When I heard the previous panelists who mentioned the basic package of health services in Liberia, one would wonder why was there not such an extensive epidemic. Well, there were missing links. So the Ebola outbreak started in Guinea, in a town that borders both Liberia and Sierra Leone. So that little town is in Guinea, but it borders Liberia and Sierra Leone. And because people walk from that town to Liberia and to Sierra Leone. So the outbreak started, and in the first place, we were all in denial that it was we didn't know where it was, and so everyone was in denial. But when we realized what it was, then there was an issue. Why is this happening? So there were many things that happened. We realized the infrastructure was not in place. We didn't have the isolation units. No hospital, in fact, had triage. So patients walk in and they go to wherever they want to go to. We didn't have the diagnostic opportunities. So even when we suspected a case, an individual having Ebola, we had to take the specimen, send it out to Senegal or to Guinea, and it took weeks before we got the result back. In the meantime, that individual has spread the disease to several other places. The health workforce was poorly prepared for response, including all of us. None of us knew how to, we didn't have the right frame of mind to be able to really set the tone. We knew that there was no adherence to clinical standards. So because we didn't have adherence to clinical standards, there were no material, no personal protective material. People touched patients with bare hands. Nobody had gloves, and so the disease went on. We finally woke up when health workers started to die. And I can tell you that we lost 3.4% of our health workforce. So the population then lost trust in the health system and refused to go to hospitals, refused to go to the centers. So we learned a lot. We learned that in the first place, we didn't have the community involved. So when a household got infected, one person died, that individual, others left and went to different parts of the country, carried the disease to those other parts. Where were the community leaders? They sat back and said, well, the health system is dealing with this. Had we involved them from the beginning, they would have probably helped us out. So there was complete lack of community engagement. So we learned the hard way.
Thank you very much, Rose. A real reality check of the need for community engagement for outbreak response. Dr. Binyam, I have a question for you. I wanted basically, community-based care and community engagement is fundamental to the underlying principles of primary health care within the Astana Declaration. And Ethiopia has really helped lead the way in this regard to improve health services. What have been your success factors to effectively increase the capacity of community health workers and strengthen links with communities?
Yeah, thank you very much, Craig. Yes, as you said, Ethiopia has been successful in implementing the community health program. We call it health extension program. And there can be many factors contributing for the success, but I pick two of the successes. The first one is the political will and commitment. That is a clear example of Ethiopia. Ethiopia hired 40,000 health extension workers paid by the government, and also recruited 3 million volunteers who can assist these 40,000 health extension workers. This is a big commitment and will from the government. On top of it, the government is really leading the community health program, unlike many other countries, which is the government is really deciding on resource distribution and the needs. So the second layer of factor is its continued improvement of the service and the management. For instance, initially when the program started, the health extension workers were expected to develop model families. Now they are transitioned to create more model communities, because thinking many of the household level behaviors are influenced by community, so there should be shared response at the community level. So now they are working on developing more model communities. The other one is service package. Due to the epidemiologic transitions, non-communicable disease is coming into picture. So now they are focusing on the health promotion with regard to non-communicable disease, plus clinical care. The community has been asking for that service, so the government has decided to push it a little bit to the community. That is the second piece. The third piece is health extension workers themselves. Previously, they were receiving a one-year training. Now they are also taking another 1 year for upgrading their skills and capacity to deliver the new service package. That's one. The other one is, as part of the motivation, they are now having an opportunity of continuing their education as a clinician or as a program manager, so that they keep on providing the service and manage the system. So this is the top prominent reasons for Ethiopia's success. And from the lesson from Ethiopia, introducing the community health program is not sufficient. but it should be improved from time to time to respond to the needs of the community.
Thank you very much. Thank you. Moving on to Clinton, can you share some practical examples with us that demonstrate the role of the private sector to strengthen the quality and equity of primary healthcare services and commodities for those that need them the most? Thank you.
Thanks, Craig. So just briefly, our organization runs healthcare supply chains, mostly in the private sector, but some in the public sector as well. And so the two examples I'll give you today are work that we've done in two countries, one in Malawi. And so the framing of this was we were involved with JSI actually in Malawi running a donor-funded essential medicines supply chain that was holding stock centrally and distributing product to all 600 plus primary healthcare sites. And our role was to run the actual central facility, the central warehouse, and then we engaged with local private sector partners to run the logistic service provision of those shipments to all those sites. And so we selected a local service provider, a local logistics company, and before we got involved with them, just to give you some examples of the impact of how we've been able to build some of the capacity of the local private sector. They had about 15 vehicles that gave them a collective 175 cubic meters of capacity, and we helped them to double the number of vehicles and double the capacity. They were delivering about 80 cubic meters of stock a month, and they're now delivering over 800 cubic meters of stock. So they have more than 10 times their productivity in terms of their ability to deliver outputs. They had no transportation management capabilities or team or department. They now have a dedicated 4-person team. There were no SOPs or KPIs. They now have that in spades. And they even invested their own $50,000 in buying a routing and scheduling software system for themselves and have subsequently become the country representative for 2 international freight forwarders in Malawi. And they now contract directly with the government and continue to sustain or continue to run this primary delivery model for the government of Malawi. So I think it's a really good example in a really low resource country. So everyone says, oh, there's no private sector in these places. Well, there is. They need a bit of help. They need to be shown some know-how, but they exist. They're there. And there is that entrepreneurial spirit and that will to want to grow their business. The second one is actually some work we're currently concluding in Ethiopia, which is a very interesting project we've been involved with, which is to take two hubs, Adama and Central in Ethiopia, and absolutely no increase in capacity, no technology, just whatever they have, the people they have, what can we do to change supply chain practice to improve performance of the hubs. And so we've had a team, on and off team of 5 people working within these 2 hubs. And just to give you some examples of the remarkable, I think, achievements that we've been able to achieve. If you're involved in the commodity space, PFSA are legendary for shutting down for their annual stock count. And for a month to 6 weeks, nothing goes in or out. And we were able to, within the Adama facility, speed up that annual closeout, that annual stock count from 42 days on average to 8. And we're just talking about the same team, the same people, just introducing different supply chain principles that are well indoctrinated within the private sector to just to apply them in their own setting. And I'm not going to go into the details, but that's just kind of one example of some of the things that can be done, that can be shared from private sector into the public sector to really help improve performance. The last thing I'll say on this is that the thing that we're implementing over the last 3 months is moving from a bi-monthly delivery to a monthly delivery. So primary health sites are now receiving monthly deliveries versus every 2 months. And it's important because one of the big missing links that I'll talk about next is got to do with trust. I think this issue in the supply chain between the primary healthcare site and where they get their drugs from, there's a big issue of trust or lack thereof that needs to be addressed.
Thank you very much, Clinton. Some really good examples there from Ethiopia and Malawi and the underlying principle of trust. Moving on to Nabila, Pakistan is center stage for many things. Its health system is to reach and deliver to a huge variety of communities, from Afghan refugees in quasi-legal status to the wealthy of Karachi and Islamabad, and from remote hills to densely populated slums. What, in your opinion, have been the main success factors to address equitable primary healthcare services, and what suggestions do you have for the future of implementing the Astana Declaration equitably?
Thank you very much, Craig. I think most of you know that Pakistan is the 6th most populous country in the world. So the challenges that we have is that majority, like 68% of the population, resides in rural communities. And that is where primary health care has a center stage. We have an excellent primary healthcare infrastructure in place. We have 100,000 lady health workers. We have 26,000 community midwives, but we are not getting the desired results. So there's something that is not being done. And what is that? It's not just that we want primary health care. We need to have political will for that, the required funding, because we see a skewed funding towards curative care and not preventive. And that's where majority of the population resides, and their needs, demands, they're there. But in 2011, decentralization took place, and health was devolved to the provinces and then went down to the district level, and that brought back the focus towards primary health care. And also we have seen that all donors, including USAID, are now focusing on primary health care. And if we are really serious, like not just aspirations, but looking at reality, we need to work on 3 areas. One, health systems, because that takes the center stage. If we want sustainable primary healthcare interventions, if we want the continuity of our efforts, that's where health system strengthening is so important. But having said that, there's no shying away from quality of care. It's not just the access to services, it's the quality of care. Otherwise, majority of people, they utilize private sector facilities, and the out-of-pocket expense is 78%. So we need to invest in improving the quality of care. It should not be, it was, I think, published in Lancet, that it should not be a thing for the elite. It should be the DNA of the programs, quality. So that is what needs to be focused. And community engagement, it's a shared responsibility. So we, as you mentioned, Amanda, that it's preventive, it doesn't bring quick results, but communities, they have to engage actively in this. And I'll share an example that in selected districts, we started an EPI program where the immunization coverage was just 14%. But by engaging communities, in a matter of 1.5 years, it went up to 87% because the communities owned it. And the writ of government was improved when the government, communities, they worked together from planning to implementation and tracking the performance and progress of the program. So I'll stop there.
Thank you very much, Nabila. Some great inputs. I'm going to be a little stricter with time on the second time around. Some really good food for thought, and I hope you're generating some questions of your own. But back to you, Rose. Resilient health systems and the need for global health security are an important concept in the Astana Declaration for primary health care. In your experience, what needs to change in planning and providing primary health care in future to make Astana a reality?
I mentioned in my first discussion that community engagement, and not when it is already planned and we go and deliver and say, this is what you need, this is what needs to be done. It is working with them to determine what they think their needs are. Once we engage the community from the start, I think that will take us far. Now, when we address global health security, it's not just, disease knows no boundary. It can move, Ebola came from Liberia to the US. There was no boundary. So we know that if countries that are contiguous to each other, there need to be a lot of cross-border collaboration. That didn't happen with Liberia, Sierra Leone, and Guinea at the beginning. And we know that this is a lesson we learned. It is a way forward. That has to be backed by strong surveillance systems where you have data sharing across the border. If we found that there is meningitis in a rural town in Liberia. The meningitis could very well travel to Sierra Leone within the next week. So we need to share the information. So cross-border collaboration with sharing of data is very important. Countries, community leaders, not just national leaders, but leadership needs to take responsibility. If community leaders feel that they are responsible for the health of their community members, they will do more. And that also goes up the line. Governments need to take more responsibility. If we continue to rely on donor, which is not bad, but what happens is the donor comes with a planned agenda. This is, I heard Laurie talking about this. I'm here to support malaria treatment, malaria in pregnancy. Only malaria in pregnancy, malaria anywhere else doesn't matter. So you have the kids dying, where the mothers are protected, but then when they have the kids are dying. So, but whereas if a government takes responsibility and leads it and takes leadership, when the donor comes, they will say, this is our plan. Please tell us where you can help us. And I think this is the way to go. Primary health care is important, and we all have to plan, but make sure that our plan, the governments take leadership in the plan, and also whatever help is coming in is not directed at what the donor wants, but what is needed for the community.
Great. Thank you very much, Rose. A kind of alignment and commitment. Dr. Binyam, health workforce retention is one of the most important gaps to extend primary healthcare platforms as outlined in the Astana Declaration. What do you think needs to be done differently in future to increase health worker retention in primary healthcare, given your experience in Ethiopia?
The health workforce management in Ethiopia has been considering two approaches. The first one is producing more. And last year, Ethiopia almost has achieved that goal. For instance, a physician to population ratio last year was 1 to 11,000, which is close to the WHO standard 1 to 10,000. So maybe next year, Ethiopia might achieve a physician to population ratio. And the other approach has been providing in-service trainings, using in-service training sites, and using other partners' resources to really build the capacity of providers at primary level care. Considering these two strategies, it shows almost we are reaching to the goal. So moving forward, what should happen in Ethiopia? The first thing is we need to know who is working where and what kind of training that person has. Because distribution might be an issue. So we need to have that information system which can really show that distribution one. The second one is when you move to the primary health care, there should be a support mechanism among different tiers of facilities or between providers working in the same facility. There are many examples which have been implementing in Ethiopia. The first one can be a catchment-based mentorship where primary hospitals are providing the necessary support to health centers, which has been supported by JSI's L10K project. And there are also been some efforts like establishing skill labs at the primary hospital so that any provider working at the health center coming to that hospital and practice on some of the skills. So there are lots of examples to really strengthen this level of care. The third piece is introducing new ways of providing training. One being using application. Mobile application is maybe one of the suggestions for that kind of training, and linking that training to the continuous professional development and licensing of professionals. So these are the three major areas that we need to focus on moving forward. And as JSI, we are very much happy to support the Ministry of Health in Ethiopia moving to this direction.
Thank you very much, Binyam. Thank you. Clinton, an often neglected but important area in implementing primary health care is strong supply chains and having product supplies and logistics in place. What are your thoughts on the future roles these have to play in making the Astana Declaration on primary health care a reality in the field?
I'll give three thoughts. and really echoing what you said about quality of drugs, I think patient safety has got to be the first step here. So we've got to make sure from a supply chain perspective that all the drugs across the supply chains, public, private, faith-based, that we've got good drugs in the system. We know from all the studies done, anything from 12 to 19% of drugs in Africa are either substandard or falsified. And so that's a huge issue. And I think that, again, erodes trust. It erodes trust for all the patients. They take their hard-earned money, they go to a pharmacy, buy drugs, and it's bad drugs. And so it's a real issue. And I think that to move anything forward in primary health, this has got to be a central point from our perspective. The second point is building on something that Amanda said in her earlier comments, which is I really think that you need to look at it needs to be looked at from the whole health system perspective, the whole supply chain. I think continuing to think about these things in public, private, faith-based silos, and then HIV, if we continue to think about these things as separate, discrete things, from a primary healthcare perspective, if you're a patient, this really isn't helpful. And so I think if we everyone talks about patient centricity, we can try and sort of work this backwards and start with a patient in the beginning and work our way backwards. What should the health system look like? How should the health system supply chain respond? It might help us reframe the way that this conversation is being held. And then the third, which underpins everything from our perspective, and certainly a huge driver in the private sector moving forward, is data. Right, so data, information, and none of this is very new, Amanda. This is the stuff I've been drumming on in the working group as well. But I think data, as we move to things like GS1 standards and product serialization in the future, we're going to have all this information and data, and what do we do with that? And where are the skills in the health system to do something with this data and this information? So analytic skills, we talk about building capacity. The future of health, the future of everything is embedded heavily in information and data. And where is the training, where is the skills development, where is the investment being made in the people in the countries to actually harness this information and do something with it to improve things like supply chains and other components?
Great, thank you very much, Clinton. So kind of quality, whole system perspective, touching on human-centered design and data. So lastly, certainly not least, Nabila, given the old saying, no money, no honey, PHC will not work unless there are adequate financial resources and governance structures to track, budget, and make sure resources flow at multiple levels to the right people at the right time to fund the right things. What are your thoughts, given all your experience in Pakistan, on making this a reality to strengthen performance-based primary health care?
Greg, I think women sitting in this room are very familiar with this term, no money, no honey. But coming back, I think funding is extremely important. But whenever I'm advocating with Ministry of Health, I never say we want more funds. I always say we want to rationalize funding, which is according to the needs. And why rationalized? We can't rationalize funding unless we have a plan. And we can't have a strategy at the national level which will fit, each and every area, because they are so diverse. So we need to have small management units. And I think decentralization plays a critical role over here. So small management units have district action plans. They are costed, present to the government. And I have seen in Pakistan that when we presented these district action plans costed to government, the finance did not take a penny out of that because we justified and rationalized. So that's important. Building capacity is so critical at all levels because we have seen in primary healthcare that budgets are not even utilized 100%. They are 60% utilization. So keeping that in mind, but I would like to talk about transparency and accountability. These are two very important things if we are talking of governance. What is governance? It means you have a better plan, you know what you're doing, you are tracking the performance, you have the capacity, you have the leadership is like political will is there, and the transparency is there. You have everything on the dashboards, people can access that, you have data information which is available for planning. So once that is there, then tracking the budget expenditure also is important. And based on that, we have seen that when we started off with chlorhexidine initiative and wanted to scale up in Pakistan, we had to go outside of the health sector. And this is where multi-sectoral approach is so critical for primary health care. It cannot be contained in the four walls of primary health care. We need education, we need communication, we need population and other areas, private sector, pharmaceutical sector. So we reached out to the pharmaceutical sector, and in Pakistan last year 4 pharmaceutical companies came forward and now they are producing chlorhexidine, which was never there. And our research showed that it reduces 38% newborn mortality, and we published that in Lancet also with Dr. Zulfikar Bhutta. It was a JSI project in the past. So that evidence, that policy was then translated into policy, and now it is scaled up to the entire Pakistan. And for the first time, we have seen in the recent PDHS a decline in newborn mortality, which was static for the last 3 years. So in primary healthcare, generating evidence is also important, but then translating it into policy and an actionable plan. Because most of the time policies are there, but we don't have operational plans. So it is very critical that we look at all these aspects, and governance is important. Without accountability, primary health care will never get the attention that we all want and the desired results.
Great. Thank you very much, Nabila. Real emphasis on kind of using data for action, getting research into policy, and the issue of kind of management units. So I'd like to kind of move swiftly on, and thank you very much to our panelists, and open it up for any questions that you may have. A huge, rich smorgasbord of many different issues coming out there, and I'm sure many of you have questions. So, and when you ask a question, please, can you state your name, your affiliation, and try and make it a question as much as possible for a specific panel member, or it might be a general question. So yeah. Lady there.
Nancy Harris from JSI, great panel. I'm not surprised. You all work in countries, in fact, there's no country in the world that doesn't have ethnic minorities and refugees. And they tend to have worse health indicators, worse access, worse everything. What kind of quick advice do you have on how to address this really difficult issue in terms of primary health care?
Okay, thank you. And the gentleman in the front.
Dr. Macaulay Charles Weiss retired from Georgetown School of Foreign Service. Dr. Macaulay gently mentioned the fact that a lot of problems stem from the fact that public health is donor-driven rather than driven by a country plan. I wonder if some members of the panel would comment on the politics of health and how they got their government to pay attention to all the issues that were described here.
Great question. Thank you. The gentleman at the back, thank you.
Yeah, also, my name is Richard from PAI. Just a quick one on accountability in terms of citizen engagement. One member of parliament from Ghana during a PHCPI Vital Science Initiative launch in Accra mentioned that he knows that primary health care is important, it's a government priority, but then when his constituents, the women in the community, they come to him, they don't talk about it. He spends his limited resources according to what the people are asking and demanding from him. So he wants to take action, but his limited resources is always will be used for what the people are asking for. So how are we engaging the communities so that when they go to their local representative, their government, they are asking them to put resources into primary health care? Because if they don't ask, he will channel his limited resources to what they are asking for, and definitely he wants votes. So how do we empower communities to advocate for themselves?
Great. Thank you very much. So I'm going to just ask, take initial 3 and wonder who wants to kind of take a stab at which, and wonder whether...
Craig,
yeah,
I'll respond
Nabila.
to the gentleman here.
Okay.
But the first question?
Yeah, and Rose, do you want to take the first question?
Yeah,
Okay.
I think every country has a minority group. As poor as a country may be, we also still have refugees who are within our community. We have refugees from Cote d'Ivoire, and we have them from Sierra Leone. I think and they form part of our communities. I think when we talk about community engagement, we need to look at where are the communities that we need to engage. I think within the refugee community, I was a refugee myself, and I can speak to what it means to be a refugee. Usually, decisions are made for the refugees. They have no input. I think if we're going to help the refugee or the minority communities, they should have a say into what services they receive and what product we give to them. It's not just the decision shouldn't just be made at a central level or made for them.
Thank you, Rose. Yeah.
Yeah, so for the ethnic minorities for Ethiopia, we have a continued analysis, equity analysis. It's happening every year. So we are helping the government to identify areas which have low service coverage and the likes. With regard to the refugee, there is a refugee authority. Health is part of their plan. So every refugee camps have their own clinics and they are receiving services. So they have health in their plan. As a government to lead the initiative, Ethiopia is well known for that one. We have a 5 years plan, and the Ministry of Health is really negotiating with donors to support the areas identified in that plan. So no donor is allowed to bring new idea and influence or change the strategies the government is following.
But how did you achieve that?
Yeah, I think the one thing is the ability to say no and negotiate. And there were many projects and donors which were withdrawing from Ethiopia because they want to bring new strategies or influence the government. The government said no. So now they are like learning how to support the government to really push its own agenda. And primary health care has been the key part of the Ethiopia system because Ethiopia has developed a 20 years vision for universal health coverage, and it is considering primary health care is the only venue to reach to the universal health coverage. So primary health care has been the top in the list of the agenda. So they are now pushing that one, and there has been so many negotiations, and some donors are putting money directly to MEDG fund pool. Now it is SDG pool fund, so that the donors are giving money to the government so that the government would use that money for the strategies or the activity that identified is important to pursue primary health care. So that's also one of the strategies that they use. So having that pool fund.
Tackle it.
Yeah, I would like to also respond to your question. What we did in Pakistan, by building the capacity at the 3 levels, at the individual, institutional, and the systems level, the government has now taken the driving seat. They have their own strategy, and donors have to align their priorities according to the government strategies which have been laid down. And we call it journey to self-reliance, or from dependency to self-reliance. We are trying to move towards that. And we saw that just last year, the government's funding in one province increased by 137%, because we said, if you have to get donor funding, you need to do what are, the objectives of that funding. So now the government, there's more and more realization that we have to move towards self-reliance, and that comes by building their capacity. So I think in the last 4 years, the JSI project built the capacity of 68 mid-level managers, and they got their masters in public health. And that's when they, put their heads together, and they have come up with a technical advisory group of their own, and they are guiding, and there is a donor coordination group that has been formed, that all donors, they have mapped the donors, and they want them to work. Although the life for donor-funded projects or INGOs has become very, very tough in Pakistan now, because it's not that they would go anywhere, start working there. So that's a challenge on this side. But the governments are feeling more empowered and,
Thank you very much, Nabila. I want to take one more round of questions very quickly, and I'll give a chance, Clinton, for you to respond to some of these. So, the lady in the second row, thanks.
Good morning. I'm Rachel Dessam with Chemonics and the HRH 2030 program. So we recognize that PHC is in the community and at these first level primary healthcare centers in many cases. I'd love to hear from you how interprofessional teams, including community health workers, can really contribute effectively to PHC.
Thank you. Great question. Thank you. Okay. Room for one more, I think, and the gentleman in the second row.
Hi, Vince Blazer, InterHealth International and Director of the Frontline Health Workers Coalition. Thanks for sharing all this today. I know the next panel is going to be talking about the global primary healthcare movement, and I was interested to hear from your perspectives how that movement, as Amanda said, and I think as evident by your talks, how everything is very country context specific, but how could this global movement be helpful and or harmful for your particular country context, and what would your advice be to some of the multilateral and development agencies who are looking at how to make sense of the global movement? Thanks.
Great. Two very, very good questions. I'm going to turn to Clinton first of all.
I'll let the other guys
Okay.
go.
All right.
Thank you.
Nabila, do you
I
wanna have a
can,
start?
I can respond because I think these are two linked questions. I think the community health workers, they have a very vital role to play. They, through interpersonal communication, create demand for services and all the misconceptions that are there in the minds, talk of family planning or talk of utilization of health facilities, immunizing their children. They do that kind of work and improve the referrals. And they also have some essential medicines, that they keep with themselves that they can immediately provide to the communities as a first responder. So vaccinators, community midwives, and lady health workers, they're all community health workers who play a very, very vital role, and we call them as extension workers of the Department of Health. Responding to, sir, your question, I think all countries, we are also in Pakistan signatory to many international commitments like FP 2020, Essential Newborn Action Plan, name it, whenever a new global drive comes up, the countries, they sign up for that global health security agenda overall. So it's not just the local homegrown primary health care, but it's the global drive which is taking place, that is also there. And we get good guidelines, like for AMR, antimicrobial resistance, which is so important, especially in our part of the world where, this is a huge issue. So we do take guidelines which are prepared by CDC, for that matter, or others, and tailor them according to the country realities. International health regulation, that's also very, very important. So it's not just the local primary health care, it's the global drive also.
Thank you, Nabila. And
Yeah,
Rose,
just
you
to add to that, I think when these global drives, what they do for individual countries is that because they are set globally and countries make commitment to participate or support, they sort of work as a driving force to ensure achievement. I mean, even poor countries like Liberia, who were able to achieve MDG 4. So it was not that there were a lot of government pay attention. We have to achieve MDG 4, MDG 5. We were not able to achieve MDG 5, but MDG 4 we were able to achieve. Had we not had that global drive, it would have been like, scattered thinking and what do we focus on. But that gave us a thing to look at and say, okay, we need to do this.
Thank you, and thank you very much, Rose. Thanks to our panelists. Just in trying to kind of wrap up, which is a hard thing to do, I was just taking notes as I was going along. 3 key messages that I had was really, number one, the need for resilient health systems that can provide quality care through human resources, logistics, and primary health care being seen as a delivery platform to deliver multiple interventions. Second, the important need for community engagement to help get them on board on the design, implementation, and monitoring of services. They can even be used for case detection and social mobilization. And third message is really aligning with country plans, country-owned plans, no more fragmentation, that includes a multi-sector approach and also increasing use of domestic resources. So thank you very much to our panel. I hope you can give them a round of applause for everything they've said. Thank you.
Thank you.
Mandela, am I saying it correctly?
Another Menabde.
Minabde, Dr.
Yes.
Minabde. Pleasure to meet you.
Nice to meet you too.
Good to see you.
Should we start clearing our throats loudly?
Amanda, do something.
See, once Amanda sits down, everyone quiets down.
All right, let's make it fun. Let's just say things we'll regret. It's usually what happens after every time I speak in public.
Only haiku.
Only haiku. That was fun. Thank you for starting that.
Oh, no worries. That'll be your chance. That'll be a way to keep it short. Just ask you to speak in verse. Well, thanks everybody for grabbing your coffee and rejoining us. I hope you're all caffeinated and energized for this second panel, which is going to follow up on the conversation we just had, the two conversations we just had about the promise of the Astana Declaration and the challenges in actually realizing health for all, with a little bit of a deep dive conversation on one of my personal favorite topics, and I think a favorite topic of many people on the panel, if not everyone on the panel, primary healthcare measurement for improvement and accountability. So, we've already spent some time examining the opportunity and the challenge. Why devote an entire panel to measurement and data? And I want to give you a little bit of background. My name's Beth Tritter. I'm the executive director of the Primary Healthcare Performance Initiative, and it's a partnership made up of the Bill and Melinda Gates Foundation, the World Bank, the World Health Organization, Ariadne Labs, and Results for Development, which is focused on transforming the global state of primary healthcare, beginning with better measurement. And last week at the Astana conference, we had the opportunity to unveil a product, a tool that we've been working on for a long time with several partner countries. And along with 11 partner countries, we released the initial round of what we call vital signs profiles, which are snapshots of primary healthcare systems at a country level. And they measure primary healthcare across various aspects of the system: finance, capacity, performance, and equity, and really provide a way that has never before been available to look across a system and try to assess how a country is doing. And what we've found based on this experience is what we've heard some of the other speakers allude to today, is that in key areas that are really important to understand primary health care, and particularly service delivery and the capacity of a system to deliver quality care that actually meets the needs of people, very few countries have the data they need to actually tell how they're doing, and to point to ways to improve, to point to how to prioritize improvement, how to prioritize investment. And in other countries, national data systems and donor requirements provide a wealth of data, but that data isn't particularly useful for understanding key aspects of primary health care that will actually lead to improvement and prioritization of resources. Or you have data sets that belong with different owners across ministries, or even among different ministries, who never really come together and take a primary healthcare focused look at how to drive improvement. So as a result, you have governments and donors that don't have the information they need to drive targeted improvements or justify increased investments, and advocates don't have the information they need to make the case for accountability, or to make the case for policy change. And the challenges, as we know, are real. There are real gaps here in performance, real gaps in the ability to reach people and meet their needs that we have to take care of. So this is not just an academic exercise of everyone wanting to know information. This is actually trying to bring about real improvement. So what we're talking about today is as we enter the era of the Astana Declaration, how do we deal with these gaps in data? How can we leverage what already exists so we're not constantly reinventing the wheel, but we can leverage what we already know to improve primary health care? And how can we incentivize countries and donors to collect and use information to actually bring about primary health care improvement in pursuit of health for all? So we have a wonderful panel today, and I want to very briefly introduce them, and then we'll launch into questions. Right here we have Jeremy Villard. He's the program manager for the Primary Healthcare Performance Initiative at the World Bank and an assistant professor at the University of Toronto's Institute for Health Policy Management and Evaluation. Jeremy has focused on health system transformation and specifically on applying data and evidence to drive change in policy and service delivery. Next to Jeremy, we have Dr. Nata Menabde. She is the executive director of the WHO office at the United Nations in New York. She's previously held positions as WHO representative to India and as a leader in the WHO European Regional Office. And she has, throughout her career, built an extensive track record in public health and health systems at the country and international levels. Next, we've got Dr. Vin Gupta. He is an assistant professor of global health at the Institute for Health Metrics and Evaluation. He has worked at the nexus of NCDs, global health security and health system strength, and just published a new assessment of the results of the Joint External Evaluation, which is a tool that helps countries assess their ability to prevent, detect, and respond to public health threats. And next to Vin, we have Ariana Childs-Graham, who's the director of the Primary Healthcare Initiative at PAI. And her career has been focused on building coalitions to strengthen advocacy on global health priorities. And she's built a groundbreaking network of civil society partners in support of strengthening primary healthcare systems to achieve UHC, promote access to healthcare, and improve health equity. So, excellent. We're very lucky to have such a great panel today. I wanted to start with Nata, Dr. Menabde. WHO plays a leadership role in the global conversation about measurement for the SDGs and advises member states on how they should be optimizing their health measurement to ensure that data can be used to drive progress. So as primary healthcare becomes a more prominent part of the global conversation on attaining SDG 3, how do we make sure that PHC measurement is integrated into other national measurement efforts? And how do we ensure that these national efforts actually connect to reality on the ground?
Yeah. Well, thank you, and thank you, organizers, for bringing us together to so quickly actually, after the Astana conference has celebrated 40 years of Almaty Declaration. I think in the first panel, we have been very lucky to hear some of the real reflections on the changes that this conference is bringing and the kind of evolution of the vision of the Almaty Declaration. But I think we are collectively still to reflect more on what has not worked and why we didn't succeed 40 years down the road to get to better results, despite of all the progress that has been, of course, achieved by many. I think there were many things also in the first panel. We have talked about the holistic and comprehensive approach which the declaration offers. But conversation really goes into logistics, capacities of health workers, training, money, and we are not talking so much about the social determinants for the primary healthcare success. And I think we need to rethink how do we change that balance overall. And now coming to the more specifics of your question about the measurements. Yes, very often there is a donor-driven and expert-driven discussion with the national governments and national levels how to design a proper measurement strategy for each country. But I think we have not succeeded because at the local level, many times those realities are different and those strategies are detached from what realities are. So data collection is actually happening, but the data is not necessarily put in action, as many mentioned in the previous panel. WHO's one of the recent studies says that providers are actually spending 50% of their time by recording different kinds of data. Not all of this is useful, and even if it is, it stays in the computer. It's not translated into something which is connected to the improvement efforts. And that, I think, is a big issue because just making sure the data is collected without putting it into decision makers' table, into policies, into other things, will not improve the either quality or coverage or any other dimensions of primary healthcare. The third thing is that we often approach it like a project, and then it is not sustainable. So sometimes it's a donor-funded project, investment into information system and measurement, etc. But these are not sustainable. They are not connected to the service delivery in a broader sense, including the hospital level service delivery and many other things. In countries such as India, as somebody mentioned in the in the previous panel also, you have a lot of private sector delivery, you have various insurance models. Those data are not talking to each other. They are not interoperable, they are not collected in a systematic manner, and they are not therefore sustainable. So we need to get from the project mode into more of an approach and more long-term issue here. The other thing is, of course, there is a lot of issue with quality of collection of this data and the capacity and skills of the workers, especially at the primary care level, to carefully, correctly measure what they are putting in action, and that's a big thing. And finally, evidence-based interventions are not always adapted to the context. So we bring good evidence, good case studies from different countries, but we try to implement them in the other context and they fail. So we need to be much more spending time on the local adaptation to the context. And for that, we need actually to connect much better to the community and legitimize in a better way the communities and community networks, because they should not be seen just somebody on the side, but somebody who is an integral part of this conversation. Finally, we need to better track expenditure all over across, I will not repeat what previous workers have said, and all that comes to the governance and accountability, which I hope we can explore further in the panel.
Excellent. Thank you very much. Fantastic points on the importance of actually using data, about the dangers of projectizing data collection, and making sure that it's sustainable and connected to service delivery. That it should be quality. The data collection should be of high quality, and the data itself should be of high quality, and the importance to adapt evidence to the context instead of just sort of applying a one-size-fits-all lens to improvement. So Vin, you've been a proponent of shifting the allocation of development assistance for health, and particularly in countries with a high burden of non-communicable diseases, to efforts that jointly address NCDs and global health security, and that can strengthen primary health care to deliver on both. So what do assessments such as the JEE, the Joint External Evaluation, tell us about primary healthcare system capabilities, and what more do we need to know to bring about a change in approach to development assistance and increase the amount of domestic resources being used to strengthen primary healthcare?
Thanks, Beth. Thank you, everybody, for being here. Amanda, Dev, thank you for having me. That's a big question. I'm going to try to keep it within 4 minutes, my allotted time. Really want to touch on 3 areas in these introductory comments. The first is, what are the shifting forces in global health financing over the last 15 years? The second is, how do we make sense of the alphabet soup of all these different indices, JEE, HCI, HDI, the Fragile States Index, to be able to make clear decisions and to actually hold primary healthcare systems accountable. At times, all this data is really confusing. And then finally, how do we utilize, once we've gotten past that confusion, how do we utilize this data in a way to seek shared priorities in global health, which Amanda had referenced in her beginning comments. I want to say, to begin with, I think conversations like this are critically important to be able to arrive at pragmatic, achievable solutions. Donor funding for global health has plateaued for the 4th straight year. In our political debate, we've openly questioned the value of global health aid, development assistance for health, development assistance writ large, and candidly, the same donor funding priorities that existed in the early 2000s predominate today, in spite, and has already been said, a shifting epidemiologic landscape to one in which NCDs dominate everywhere. And yet donor funding has not kept the pace whatsoever. And to drive home that point, development assistance for health represented 2.2% of all allocations in 2017. That's about $820 million of $37.4 billion. It's not just absolute figures that I'm trying to cite here, or relative numbers, but I think that says something about how donor priorities are not where the rubber meets the road. In my view, this discrepancy between what we're seeing in disease burden versus what we're seeing in relevant financing is directly the result of policymakers not really having clarity on why NCDs should matter to them, why that global burden of NCDs should matter to them, and in turn, why primary healthcare system strengthening should matter to them. If they're seeking re-election, they're trying to fulfill a populist agenda. And I think that observation is also supported by the fact that there's been 2 prior high-level meetings at the UN level in 2013 and subsequently in 2015 that talked about NCDs, similarly to what just happened in September. And none of those were followed by actionable donor commitments in terms of increased financing for NCD-related initiatives. So onto my second sort of area of focus, importance of data for accountability. Lots of data, lots of indices exist currently. To name a few, the Joint External Evaluation, which I'll mention in just a bit. IHME's Healthcare Access and Quality Index, which I particularly like. Human Capital Index by the World Bank, also one published by IHME. The Fragile States Index, which I think has really interesting health-related connotations. All of these measures, in my view, are helpful because they create headlines, they draw media attention, and it forces some degree of political action, or at least some degree of political attention. So in and of itself, that's helpful. That's important since for the majority of health-related financing, the most health aid-dependent nations in the world, at most 30% of their total health spending comes from donor aid financing. 70% of the most health aid-dependent nations in the world have to locally finance their health systems. And so domestic health financing is really the key, and at most we can hope that development assistance for health provides proximal momentum, which is, leads into my final point, seeking shared priorities in global health. I've personally spent a lot of time working with the Joint External Evaluation results. There's 55 such assessments. I don't have the time to get into what the JEE actually does in depth. The bullet point here is that it assesses a country's ability to prevent, detect, and respond to the next pandemic or pathogen with pandemic potential. A lot of money's gone into it. WHO is very invested in it. Colleagues and I published work analyzing results from the first 55 countries that underwent the assessment in the Journal of Global Health. And briefly, and I'll conclude with these just final few points here, adequate numbers of trained health workforce cadres and laboratory capacities were severely lacking across most countries in the Southern Hemisphere. And I can elaborate on what I mean by that. But if we acknowledge that the biggest voids in preparedness are those ingredients, we should also acknowledge that a health system that's contending with a high NCD burden needs those very same capacities. You need trained healthcare workforces, you need laboratory capabilities to address diabetes, hypertension, chronic renal dysfunction, any litany of chronic maladies. And so I'll conclude with this, just giving a nod to Amanda's initial comments. The enormous political and whole of government interest in global health security, I think, presents an opportunity for us in civil society to help broaden donor funding priorities, to at least consider NCD-related allotments. And I would suggest, and we've written about this to some degree, a multinational funding stream akin to the Global Fund that's focused on these two ingredients, strengthening healthcare workforces. The first panel talked about specifics in which you need more resources, strengthening subnational laboratory capabilities, so at the proximal end they can detect hemoglobin A1Cs, at the distal end zoonotic disease transmission and priority testing. I think some type of funding stream that's focused on this would have political will, political backing, because it has the GHSA imprimatur on it. It would have clear proximal effects on primary healthcare system strengthening, and also make inroads on the burden of NCDs. Thank you.
Excellent, thanks very much. And important points on the sort of fundamental discrepancy between the disease burden and what we actually spend our money on globally. On the importance of leveraging the sort of, as you called it, the alphabet soup of indices and assessment tools for accountability, and the fact that even though they might not all be aligned and it might be difficult to use them all together, each in and of itself provides a level of sort of push and political momentum for policymakers, particularly at the local and national level, to make decisions about domestic resource allocation in addition to donor funds. And then if I might take the liberty of paraphrasing, perhaps looking at issues related to global health security and NCD burden through a primary healthcare lens could help us focus in our resources to where they can be useful across different priorities as opposed to for specific work streams. So Jeremy, you've had the opportunity to work with several countries to apply a primary healthcare lens, as we were just talking about, to efforts to address key global health challenges, both through regular World Bank programs and also through some of the investment case preparation around the global financing facility. Can you discuss where information or the lack thereof about the quality of primary healthcare service delivery fits into the equation, and how more data on quality of care can help shape investments in global health?
Thank you, Beth. And I'm actually talking about two countries. I'm going to talk about Senegal and Tanzania, where I've been very, deeply involved, working, with the government on World Bank operations and more broadly with partners, trying to understand some of the root causes of poor outcomes and little progress we've seen in maternal mortality, child mortality, and across a range of issues. And the first thing I will acknowledge that these are actually very data-rich countries, and that is actually far from being the fact. In many countries, in Senegal and Tanzania, you can actually do a lot of deep analytical work. You can look at variation between, at facility level between public and private sector. So we have a wealth of information which we don't find in other countries. But what I've found actually very interesting is the commonality of issues in those two countries. And I will probably say, at the bank, we've been working in about 15 countries over the last 3 years, carrying out the primary healthcare diagnostics using the PHCPI discipline way of thinking through spanning functional capacities, access, quality, coverage, and health inequalities. And what we found is actually, remarkably consistent. We found countries that underinvest in primary healthcare because it's easy to do, because very often donors actually will compensate your lack of investment. So we see countries that spend 1 to 2% of GDP on health, and probably about 15 to 25% of their government expenditure on primary healthcare. And you see obviously a big contradiction with the potential benefit of investing in primary healthcare and factually how much investment that they make. What we see as well is, despite the recognition that what we need is comprehensive primary healthcare, especially because of the change in the burden of disease and the emergence of NCDs. In Senegal, it's about half of the burden of disease today. So we need actually primary healthcare systems that are equipped to address the challenge. And of course, the systems are not. If you go to any healthcare facility in Senegal today, and we've done it in any public or private facility, you look for a clinical practice guideline on NCD management, you will not find one today. You will not, like we've done it. But then, of course, when we look at the quality of services, and few studies have done that systematically, and I think the value of the work that we've been doing with PHP is really to bring all these things together. We're really shocked by the results. Ability of a provider to diagnose correctly for a common condition, 1 out of 2. 1 out of 2, like the best results we have in Sub-Saharan Africa and Kenya, 70%. And we're talking about very simple things, ANC, PNC, family planning visits, sick child visit. If you ask in Senegal or Tanzania to a mother after she comes out of a visit with a primary care practitioner, if she knows what's the diagnostic with her sick child, 7% will know in Senegal. And that has not changed over the last 5 years. It's a little bit better in Tanzania at 25%. But you see that there are actually very important issues related to quality of care. And so what's really useful to us is that it helps us change the dialogue with government about what should be the focus of their priority investments and interventions. And so what we've been doing, of course, is use the instruments at our disposal. We, World Bank, but we work also very closely with the WHO Commission and now with more partners, Gavi, Global Fund, as country offices, we influence in their own ways, and as we have country-level platforms, try to push the issues. And so I'll just give maybe a couple of examples. In Senegal, we've developed a comprehensive set of interventions that really focus on trying to retrain providers, change the curriculum in med school and nursing school, try to push minimum standards of quality of care. Also try to identify innovation, because there's lots of innovation on the ground that is not spread or scaled. And so we try to help them do that. So there are lots of interventions in the short term. At the same time, we use some of our more innovative instruments. So we have now actually ways to engage over a 10-year work plan with governments. And so we try to have indicators, and we try to link disbursement of financing to the achievement of those indicators. And for example, levels of primary healthcare spending is a very good candidate for that. In a country like Tanzania, what we see is a little bit different. We see very high maternal mortality. And that's related to the fact that there's a policy to tell every woman to deliver in low volume dispensaries where it is unsafe, very dangerous care. So we're trying actually to think about system design, back to your point, Amanda, and try to get actually women to deliver in the right place. So I'm giving you some examples. The reality is that we focus very strongly on levels of primary healthcare spending, domestic resource mobilization. To your points, exactly for the points that you were making, Vin, which is this is the only way to make UHC strategies sustainable over time. We need to be trust in populations. Levels of trust in health systems are very low if you look at the results of the Lancet Commission, and it only comes with quality at the front line. And so, I think that all solutions don't work to improve quality. The gap is too big. You need to involve the private sector. You need to think outside of the box, think about innovation that's going to make a difference for the people. And finally, you probably need to do two more things: empower local communities, so local scorecards. Yesterday, we had a wonderful example of the Guatemala healthcare defenders, who are volunteers who are actually trained to promote the right, not only the right to healthcare, but the right to quality healthcare, and they're very active in their communities, and that pushes up the level of expectations and dialogue with providers. And the last thing we need, of course, is also high-level advocacy. We need to escalate the issues, and what happened in Astana, what's happening with the Human Capital Project at the bank, where we say that health and education is actually key to future economic growth, are all very worthwhile initiatives to put those issues on the table and force the dialogue, among partners and, of course, led by governments about ways to do things differently. Because now we're not making a dent, and as NCDs grow, this is going to become more and more of a challenge over the years.
Excellent. Thanks, Jeremy, for the deep dive into quality and I think a peek under the hood at some of the things we've actually been seeing in countries, which I think show the magnitude and the depth of the challenge in actually achieving quality primary health care for all. Ariana, we've heard a lot over the last couple of weeks at the conference in Astana about the primary ingredient of primary health care improvement being political will. And I know we talked a little bit about that on the last panel, but from your work organizing different stakeholders in civil society around the need for a greater focus on primary health care, can you talk about how data can also promote political will and accountability for the commitments that governments and international organizations are being asked to make?
Sure, thank you. I think first of all, it's important to talk a little bit about sort of what we mean when we say political will, and I think sometimes there's an image of a single statement being made in a public venue, or someone went on the record, or even better, a policy. And I think what's really helpful to unpack beneath that are all of the layers of the actors who came together and made that political will possible, either who had the vision or the intent that political will was important, that kind of expression by that particular policymaker or decision maker, community leader was important. That it's not a singular moment, that it's a very sort of dynamic process. And so even if there's been an expression of political will, it's something that is a living, breathing, it's like a child that sometimes it's like adorable and so cute and you want to take pictures, and sometimes it won't stop crying. And so I think,
Run away.
when we bring in sort of the data piece about the relationship between data and political will, we also have to understand that data in and of itself is not a solution. That data is also in service to being in conversation with the political will, sort of the expression of the political will, those who made the expression of the political will, and all of those drivers at every single level, from every single seat, who are making that political will possible. And data in and of itself is not, it's not objective. It can be benign. it can be weaponized. And so I think also really unpacking who has access to the data, how is that data being used, what was the intent of the data before it was collected, packaged, disseminated, who holds that data, who is not allowed to have access to that data, and recognizing that the decentralization of data isn't necessarily a negative thing, that having data systems that have communication pathways is what's really important also. So I think also looking at whether they're sort of global data collectors, disseminators, whether we're talking about data at the community level or clinical level too, that to not sort of pit those different data sources against one another, but also look at the value that they're bringing to the table. And as Beth mentioned, I am a chronic coalition junkie, I like to think sometimes. Just can't stay away from it. And one of the things that happened in the lead up to the Global Conference on Primary Healthcare was the development of a civil society statement. This was one of a couple of different statements that came together in the lead up to the conference. And through a consultative process starting in August, because if you want to get a broad set of stakeholders together, from the Planned Parenthood Federation of Liberia to the Palliative Care Organization in our coalition in Ecuador, to come together around a shared set of principles, you need to start early. And please don't let me convince you that this is the end of the conversation. It's a very live conversation still. And I won't call it a consensus, but I think just to point to a few of the recommendations that came from this statement also regarding accountability, one of the recommendations was to democratize and make inclusive the governance of public health by empowering and engaging communities. When we talk about civil society, I think particularly in DC, we think a lot about advocacy and advocates who sort of hold that seat in civil society. But when we're looking at the country level, that thinking about trade unions, formal and informal health workers, educators, academic medical centers, health profession schools, health committees that form, there are all sorts of layers that have a stake in what this data is telling also. Another recommendation was improving the quality of data, measuring the performance of primary healthcare systems and health outcomes to drive investments and improvements while minimizing reporting burdens on the frontline health workers. I think that's also one of the things that came out in the PHCPI launch last week, hearing from a number of the public sector representatives was, this is not data that is to be, published and, sometimes we talk about putting data on the shelf or putting data into reports, but it's really data for the use and application to improving primary healthcare systems and looking at what the actual needs are. And so I think when we're talking about the connection between political will and accountability, data helps us be specific about pinpointing where the challenges or the problem areas are and matching the solutions to those challenges. One practical or specific example is in Ghana, which is often held up as an exemplar of strong primary healthcare system with the CHIPS model. I always forget what CHIPS stands for, community health. Someone else wants to fill in the blank. In a really strong, widespread, breaking through many of the barriers for geographic access. And one of the things that was discovered by some research that was done by Ariadne Labs was looking at the bypassing that happens. So a perception of poor quality that was offered from the primary healthcare level and folks seeking out care in hospitals or other health centers. And that kind of information helps to tailor what the response is about how to actually leverage the resources, leverage the infrastructure, leverage the political will to do better by the people.
Excellent. Well, thanks, Ariana. And you raised some really important points about sort of the people-centeredness of data. And I think also built on some of the words that Nata offered in terms of the interoperability of different data sets and systems. I'm told our time is up, which I think is horribly unfair to those who might have questions. So I'm actually wondering if, since my mic is on and they haven't cut it yet, we could take just 2 really quick questions.
No, we have time.
Is that okay?
This is start of Q&A time.
Oh, start of Q&A time. Okay, sorry, I thought my time was actually up. Okay, this is start of Q&A time. So we can take, we'll do 2 rounds of 3 questions each. And if, as with the last panel, thank you, you could identify where you're from and who you are, and then make your question as sort of brief and to the point as possible. That would be very much appreciated. So I see the first question over here.
Yeah, Daniel.
There's a microphone coming your way.
Hi, I'm Daniel Kotliar from the World Bank. Something that people coming from the outside are sometimes surprised about is the fact that we don't know how much money is being spent in primary care. And there seem to be many good and complicated reasons behind that. But since this panel is looking at measurement and performance, now that we're celebrating 40 years of Alma Ata in the future, will there be a measurement of how much countries are spending, how that varies over time, comparisons across countries? Is that important? Has something changed now that this 40th anniversary is here that will allow a measurement for the future? Thanks.
Excellent, thank you. We'll take another question. Oh no, sir, with the red tie, that's you.
Hi, I'm Jeff Sanderson. I'm with JSI, and I work with Dr. Macaulay on post-Ebola programs in West Africa. But my question is sort of more basic, which is quality is a lot of different things. It's how the services are delivered, what their skills are, but there are also some, and you mentioned it, Jeremy, basic minimum standards. And it could be facilities, it could be the tools and the equipment that the providers have to offer those services. But one of the most basic in the lowest income countries, and I think we tend to forget it, is access to water. If you're trying to run a facility without water, if you're trying to do IPC and surveillance and other disease prevention issues without water, how do you accomplish that? And I think I have a sense that sometimes we talk donors and others way up here, which is all really important, but we sometimes forget that sort of basic level in certain countries. And I wonder, in delivering primary health care, how we ensure that we stay focused and we help governments stay focused on those basics.
Excellent, thank you. And then did I see another question back there in the corner?
Hi, I'm Ida Zhang from HelpAge USA. My question is about related to non-communicable diseases. And so everyone knows that NCDs are a huge burden and that it's the largest cause of death, but there's not enough funding to address that issue. So my question is, how can we use these kinds of best practices that you mentioned about utilizing data to kind of emphasize this link between NCDs and poverty, and using that argument to build this political will, either at the community level or any other upper levels.
Excellent. Okay, so we have 3 questions, and I'll let our panelists think about how they want to answer them as I just recap. The first is about measurement. Are we going to actually start measuring what's spent on measuring finances? Are we going to actually start measuring what's spent on primary care as a way to track our progress towards these new commitments? How do we encourage sort of basic minimum standards of quality, including access to water, by some of these measurement methodologies? And how do we convince governments that it's an important thing to invest in as part of primary health care? And then finally, how do we emphasize the link between NCDs and poverty? So I wanted to turn to the panelists and see who wants to take a crack. Excellent, please.
I think there is something common across all 3 questions, because they are going besides of the traditional Ministry of Health territory, where you are dealing with provision of services, and in many countries ministries are doing just that. They are not steering the system, they are providing services. Right. And I think one of the mistakes, or not mistakes, but maybe factors which was decisive in Alma Ata conference 40 years ago, not getting us where we want to be today, is that all of that conversations were mostly within the ministries of health, And then we're talking about issues which are outside of the Ministry of Health. There are many things like determinants, and holistic vision of the primary health care has never crossed really, truly boundaries of the Ministry of Health mandate. And that's why the problems have also remained. And that's why we don't know what is spent on primary health care if we look at all the aspects of it and multi-sectorial nature of it. So I think this is a different world now. We didn't have at the time the civil society. We didn't have so much of a private sector. We didn't have many things 40 years ago. And then we continued to do what was said then. And I think that's a mistake, or it's something which we should learn from. And I do believe that indeed it is very important to measure what we are spending in primary health care, both on services proper at all levels and also to look at equity and all the other aspects. But it's also important that we are looking at all the elements which are falling outside of service delivery, which are determinants like water, for example, and access to safe water, but also access to hygiene and also access to many other things. We need to look at this data across the sectors. And of course, this whole SDG thinking in which we are currently these days helps because it clearly establishes interconnectedness between all these different goals. And let's not be silly to think that we can advance primary health care in the countries where you are not having education level going at the same time, and the environmental policies are not right, and the poverty issues are not properly addressed. And of course, that means that we really need to bring not just primary health care, but the whole health issue has to be much higher in the governmental conversations than it is now. And we need to see how are we going to be strengthening, transforming, or changing the role of the health ministries. Are they going to be stewards of multi-sectorial action for health? Do they have that authority in the government? Are they going to be listened? Are they going to be heard? Or do we need to rethink and see what are we going to do about it? Because it is all outside of service delivery. Service delivery is a response to epidemic or pandemic, if you will. Something happens, so you treat. But it doesn't deal with prevention, promotion, etc. NCDs, we are never going to get money to treat all the cancers in the world. Everything is growing, and etc. But we can do something about climate change. We can do something about environmental pollution, which is not in a health service provision territory. So we need to see how are we going to tap those actions of other sectors. And indeed, NCDs are a problem for the development. They are determinant of development. There is data on that, but not enough, not well articulated, not well advocated, and not right people talked about this. So my question about the Almaty conference is, who was there? Were there people whose action is required, or were there most of the people who are already convinced, already have data, already are there? And, are we talking to the already people who are in the center of this movement, or are we able to reach with this outside to those who need to take action? And I think that cuts across all three questions.
Yeah, that's a really good point about making sure that as we embark on this journey, we're not always preaching to the choir and building are building sort of ever stronger and ever broader coalitions around the importance of this. Jeremy, did you have a comment as well?
Yeah, maybe on the first two questions. So on spending, there's been an effort from, through the PHCPI partnership, WHO and the OECD have redeveloped the system of health accounts in 2011, and so there's an effort to try to actually capture primary healthcare expenditures. It's difficult, it's complicated, but about 50 countries have been working hard over the last several years to get to an estimate. And so in early December, there'll be a release of the data for those 30 countries. You can see actually on our website that we have for several of the countries for which we have vital signs profile, we have actually released some of those early results. The data is not perfect. There are quality data issues, but we believe that putting the data in the public domain is going to create and stimulate countries to work on improving their accounting system so that we can have actually better estimates of primary healthcare spending. The issue of quality and access to water, absolutely. That's I certainly agree. In the work we do, trying to evaluate broadly the performance of primary healthcare systems, we've developed what we call a progression model, which is a way to look at quantitative and qualitative indicators and methods to really understand all the functional capacities of primary healthcare systems, from policies and governance to all the basics in terms of inputs, information and financial flows, availability and distribution of human resources, and then organization and management of services, taking a population health lens. And so access to water is certainly one of the things we look at. But this is, and yes, we need to pay attention to the basics, but this is not sufficient. It's a necessary condition for good quality of care. This is not sufficient. So I think we have to think about it in a context of all the other things that we need to do. And I'm saying that because I'm worried when I talk about quality in a country. I have colleagues saying, well, we're going to put water and electricity and solar panels in every facility and things would be better off. Well, yeah, but that's not how you're going to make a dent in poor health outcomes. So,
I just had a quick comment on the third question. It's a difficult question. I don't have a great answer, but what I can say is linking NCDs with poverty through data. Our data right now, the JEE, the Healthcare Quality and Access Index, it's national at scope. There's minimal granularity. There's just 7 countries that have subnational information for the Healthcare Quality and Access Index. So when you're approaching somebody, if it's in Indonesia and you're talking to mayors or district, provincial leaders, we can't really give them meaningful, actionable data other than what's happening at the country level. I'm thinking tobacco control policies. And so I think we have to be able to tell a better story. And that's happening as we speak. But right now, the data we do have often is at the national, not at the subnational level.
Did you have anything you wanted to add?
Sure. I think just a kind of blanket statement about the importance of country-driven solutions, which feels really obvious to state. But I think we can't say it enough that one of the important things about sort of looking at global trends and conversations is it opens up resources, it helps make sort of better connections among different stakeholders and players. But ultimately, I think what we're talking about, whether it's about looking at sort of that multi-sectorality or disease burden trends, financing, all of these things, all of what matters is sort of what is the country context and how our public sector, civil society, technocrats, all of the different players that are coming together in the constellation at the country level to drive progress, to improve health outcomes, and really sort of the clarion call of the Astana Declaration and a continuation of Alma Ata was being people-centered. Right? Ultimately, what we're looking at is what are the needs of individual people and how to meet those needs. So I think what we're, just sort of reinforcing the importance of equipping and driving the attention and resources and decision-making power and authority to those folks, both government and civil society, that are making those decisions at a country level.
Excellent. We don't have a whole lot of time left, but I think we do have time to take like 1 to 2 other very quick questions, even if they just turn into sort of questions that we leave out in the ether that we can take home with us and think about for the rest of the day. Yes, ma'am. Yes. Sorry. Oh, need to get her. There you go.
Thank you very much. I would like to ask and go ahead with questions, general questions for the panelists. We're talking a lot about the political will at country level, and this is important, but I think it's another aspect that is the political will from the global developers, donors, implementers. It's clear that it's a challenge, or has been a challenge, that this political will is not clear. We have in Astana, we saw, and previously, that is an agreement about the general concepts, health system strengthening, sustainable development goals, primary health care, many others. But there are few advances in how this political will from the implementers, even our contribution financially is very low, 30%, but it's an important example, and it's very difficult to promote this because, in fact, we are part of the lack of political will at some point in the countries. This is one part of the question for if you have ideas. And the other is, again, ideas or suggestions about we are promoting this political will. This implies, and according with this panel, implies a better data collection and mostly, and the most important thing, data use in order to improve the management and the system. but we need to find who identify, that is already you mentioned about who will be the ones maintaining and promoting this culture of data collection and use in order to improve primary health care. And for sure, at least it's my idea, it's not us as the donors, as we need to be sure that at the same time that we're promoting this, we are building and growing this culture in country, and the ones that they are going to follow disregarding the political party that is in the power.
Excellent, fantastic. Very important points on building global political will and also creating a culture of data collection and use. And probably the capacity as well, I think, is something that we've heard some talk about today as well. Ma'am. And then you're going to be our last question.
All right, thank you. My name is Anu Rotimi. I'm from Health Reform Foundation of Nigeria, AFON. My own question is really about the issue of data and time effectiveness. You know, I know Fix mentioned something about effectiveness of health workers, the time management, them spending so much of the time collecting various tools, using various data format. So what are we really thinking for us to be able to ensure that health workers at the facility are more effective, and we actually have maybe common ground of data collection for multiple interventions, so we don't, because we need to start accounting not just for the money, but for the time, for the human resources, because we know the more we spend, give them various tools to fill, and they spend, and we take them out of their workstations for meetings, for a lot of surveys and things. The people are actually suffering. So I think it's important for us to start looking at how do we ensure that we have a generalistic format, and the use of IT to ensure that we were able to effective. Then the other part of my question is you have accountability.
I apologize. I'm going to have to stop you right there because I'm about to get a very nasty-looking red sign that says we're out of time.
The issue of accountability.
So if you could just wrap up in the next 10 seconds.
So the issue of accountability, I think, is very key, and I think we as civil society, we seem to start taking the front role in terms of becoming the citizen ourselves. I think we need to start giving the citizen more voice so that they become more accountable for the action that happens to them.
Excellent. Thank you very much. And so what we're going to do now, because we're over time, is I'll call on two of our panelists to provide a lightning round, 30-second, as pithy as you can get in response to the excellent points that have just been made, and that will bring us home. Who'd like to take a crack at it? I'm giving you 30 seconds to shine.
Absolutely. Community members, individual members, their voices matter, and it's often the relationship not only between the provider but sort of local governance that is important. So, all of those kind of communication pathways, ways of organizing, ways of understanding, and really thinking about people not only as patients but as people who have a capacity and responsibility for themselves, their families, and have a real role in maintaining their own health as well.
Excellent. Thank you, Ariana. Anyone else? 30 seconds? Excellent. Jeremy.
I'll give it a try. The dialogue is changing. This is about long-term spending. This is about quality of care that benefits clinically patients. This is about comprehensiveness of services because of the change in the disease burden. There is an approach, on human rights to healthcare, but I think that what the bank is doing right now is the work on human capital that some people will criticize as being too utilitarian, actually also has the virtue of linking investments in health and education to economic growth. And that's an argument that has lots of resonance with ministers of finance, and you need them on side to be able to push for greater results, more accountability, and really create a movement for better results. That's what people deserve.
Excellent. And I'll use my discretion to let our other two panelists take 30 seconds to wrap up themselves as well.
I think I will. I want to respond a little bit to what you have mentioned. Indeed, the global governance of health is at the moment in a very opportune situation. It's a clear change of paradigm of thinking about global health issues. There are a number of important directions that have been set. There is a lot of discussion and negotiation that is happening now, like in the context of creating a roadmap for the implementation health SDGs, for example. There is a big engagement happening now. And I think where we are seeing challenges, how do we link work of different players in delivery of all this together. How do we engage them in consultation? Not just big donors and big partners, but also communities and their representatives and legalized networks of those people who have legitimate concerns about the quality and services that they are benefiting from. So there are processes which have been planted and they are going on. We are moving towards the universal health coverage meeting at the General Assembly of United Nations in September 2019. This has to come up with something which is politically really strong, powerful declaration, which has to build on all the things that are happening. But we are here between Astana and the next one will be in September in New York. We have to spend this time at every level, at every country, in every global health debates and discussions to bring it up to the level which is capturing all these concerns and issues which are being raised. And then the declaration which comes up in New York kind of is an answer to all the big issues and challenges that we have on the table, not just for the global community, but also at the country level and at the local level, etc. So I think I just want to bring this up. Let's gear towards that movement and get some meaningful answers to many questions that are not so easy to answer, maybe in September. And that will bring us to the level of heads of states. And that's where we can maybe reach out to unreached and talk about bigger political will.
Excellent, thank you. You have 10 months to rise to this challenge, so which should be plenty of time. And then Vin.
I'll keep it to 20 seconds. Just lots of comments on political will. Somebody that works with data, frequently different types of data, I don't think that's what's going to get us there. I think it's going to be looking for shared capabilities, shared priorities in global health, and taking advantage of the moment and what's politically a hot button topic. And I think right now that's pandemics, and I think that affords us an ability to make some inroads on NCDs. I'll leave it at that.
Excellent. Well, thank you very much. And thank you, before we do a round of applause for our panel, I just wanted to thank everyone for coming. I wanted to thank our host, CGD. I wanted to thank our co-sponsors, JSI. And thank you all for spending your morning with us talking about this important issue. So a round of applause for everyone.